This video is going to be discussing the concept of tissue integrity, and the exemplar that we'll be using is major burns. These are the student learning outcomes for this topic. They're going to be located on the tissue integrity tab in Canvas. You're going to use these student learning outcomes to guide you as you study this material. This is a slide showing the three different layers of the skin: the epidermis, dermis, and subcutaneous tissue. And as you can see in this picture, there are a lot of things that are housed in the different layers of the skin. I put this picture in here to show you what could be potentially damaged when a patient has a burn that affects especially the lower areas like the dermis and the subcutaneous tissue. Now let's review the pathophysiology and etiology of the four types of burns. Thermal burns are a result of exposure to dry heat from a flame or moist heat from steam or hot liquids. Frostbite is also considered a thermal burn. A contact burn occurs when the skin comes into contact with a hot object. Heating pads can cause contact burns and are especially dangerous for someone with a neuropathy. Direct exposure to a thermal burn can cause cellular destruction that could result in charring of vascular, bony, muscle, and nervous tissue. Chemical burns occur through direct skin contact with either an acidic or alkaline agent. These types of agents are often found in household cleaning supplies. Acids will burn the skin through the process of tissue coagulation. Alkaline agents like ammonia or oven cleaners are more difficult to neutralize and result in deeper tissue damage. Electrical burns occur when a person encounters some type of electrical current. The severity of an electrical burn depends on the type, duration, and voltage that they come into contact with. Assessing an electrical burn is often difficult because all you're going to see is the small entry and exit wound. Electricity follows the path of least resistance, and this path tends to lie along muscles, bone, blood vessels, and nerves. There may be widespread internal tissue damage that may not be evident until weeks after the initial burn event. Often, tissue necrosis results from an impaired blood flow secondary to blood coagulation at the site of an electrical injury. Electrical burns often result in cardiac dysrhythmias or cardiac arrest by interfering with the electrical activity of the heart or by direct heat to the myocardium. Electrical injuries are associated with post-injury mental health issues, including depression, anxiety, as well as post-traumatic stress disorder. Radiation burns are usually associated with either sun exposure or radiation treatment for cancer. These burns are going to be localized. The time between exposure to radiation and the clinical symptoms may be days to weeks. Radiation symptoms may include a headache, chills, localized pain, nausea, and vomiting. An inhalation injury is caused by exposure of the airway to heat or toxic substances. The inhalation of heat causes immediate injury to mucous membranes of the upper airway. An inhalation injury causes inflammation, edema, and airway compromise. Inhaling noxious gases irritates alveolar tissue. It decreases ciliary action. It increases mucus production, causes edema, as well as bronchospasms. Carbon monoxide, which is a compound found in smoke, displaces oxygen as it binds to hemoglobin, which is going to impair oxygen utilization. Patients involved in any type of fire are at risk for an inhalation injury and should be assessed for the presence of singed hair on the scalp, loss of eyebrows, burns, or nasal singeing or facial singeing. The nose should also be swabbed to detect the presence of black soot. Patients with an inhalation injury should have a carboxyhemoglobin level drawn. The normal carboxyhemoglobin level is usually 0 to 5%. A patient should be placed on 100% oxygen via a non-rebreather mask. Patients with elevated carboxyhemoglobin levels may need hyperbaric oxygen therapy. This is some of the criteria for referring a patient to a burn center. If a patient sustains a burn to the face, hands, feet, genitalia, perineum, major joints, or if the burn is caused by electricity, chemical, or an inhalation injury, these patients should be referred to a burn center. Any kind of partial thickness burn or greater that is greater than 10% total body surface area. If a patient has comorbidities that may complicate the management, prolong recovery, or affect mortality, these patients should be referred to a burn center. Any kind of full thickness burn, or if they have a burn as well as major trauma such as a fracture, they should be referred to a burn center. Children with any kind of burn should be referred to a burn center, and burns in patients who require special social, emotional, or rehabilitative interventions should be referred to a burn center. Burns are classified by the total body surface area involved and the depth of the burn. Superficial burns involve the epidermal layer of the skin. The burned skin is going to remain intact and should heal within 3 to 6 days. You may see peeling. Treatment for superficial burns include mild analgesics, water, soluble lotion, as well as aloe vera. Partial thickness burns involve the epidermis and the dermis. Depending on the depth, they can be categorized as either superficial partial thickness or deep partial thickness. A superficial partial thickness burn includes the top portion of the dermal layer of the skin. The burn is often bright red and edematous. Capillary refill is usually intact. These burns are very painful, and healing is going to occur within 21 days with little or no scarring. Deep partial thickness burns involve the entire dermal layer of the skin. The wounds are going to appear white and waxy. These burns affect capillary refill. These burns will heal within 21 days usually, and scarring is likely to occur. Full thickness burns involve all the layers of the skin and may extend into the subcutaneous fat, connective tissue, muscle, or bone, and are caused by prolonged contact with the source of the burn. These burns are going to require skin grafting in order to heal. Depending on the cause of the burn, full thickness burns may appear pale, waxy, yellow, brown, mottled, charred, or non-blanching red. The wound surface is going to appear dry, leathery, and firm to touch. The leathery skin is called eschar. There's no sensation of pain or light touch at the site because pain and touch receptors have been destroyed. The extent of a burn is expressed as the percentage of total body surface area burned. The rule of nines is a rapid method used to determine total body surface area for both partial and full thickness burns. Circumferential burns result from an injury that encircles an extremity. Edema and peripheral vasoconstriction also occur to further decrease blood flow. Circumferential burn wounds to the neck, chest, abdomen, digits, and extremities are at risk for the development of compartment syndrome. Compartment syndrome can develop quickly during the resuscitation phase because of massive fluid shifts. Compartment syndrome develops when tissue pressure in a muscle compartment exceeds microvascular pressure, interrupting cellular perfusion. Patients with major burns will need multiple surgical interventions. Initially, the patient may require an eschorotomy. An eschorotomy is an incision made through dead tissue to release constricted tissue and allow blood flow to the affected nerves, muscles, and organs. Usually, several incisions are required to release the constricted tissue. Major burns will require multiple surgical debridement as well to remove damaged tissue. This slide, which is also located in your book, shows you the systemic effects of burn injuries. You should review this when you're studying this content. The first phase of the burn is called the resuscitative stage. Burns involving that involve greater than 20% total body surface area are likely going to require fluid resuscitation to counteract the intravascular fluid losses resulting from increased capillary permeability. Patients should receive fluid as soon as possible to avoid the development of hypovolemic shock. The Parkland formula is commonly used to calculate fluid resuscitation. The formula is calculated as 4 times the patient's weight in kilograms times percent of total body surface area burned. The patient is going to receive half of the total volume of fluid over the first 8 hours, and then the other half of the remaining fluid is going to be given over the remaining 16 hours of a 24-hour period. We're going to work the Parkland formula out during a case study that's presented during class to make sure y'all all understand how to calculate this. During the resuscitation phase, a primary assessment is going to be performed and the fluid resuscitation is going to begin. The goal of resuscitation is for the patient to maintain adequate urine output on a maintenance rate of fluids. Patients are going to receive crystalloids like lactated ringers during the fluid resuscitation phase because it's slightly hypotonic and treats both intravascular volume loss and extracellular sodium losses. The nursing role during the resuscitation phase is going to include the administration of fluids and continuous monitoring of the patient's status. Hourly urine output measurements are going to be the gold standard by which fluid resuscitation is going to be monitored. A urinary output of 0.5 to 1 milliliter per kg per hour is recommended to maintain adequate renal perfusion. Fluid rates are going to be gradually decreased as urine output is maintained. Burn resuscitation is considered successful when the patient has adequate urine output after fluid administration at a maintenance rate. Vital signs are also going to be monitored. Acceptable parameters include a heart rate of up to 120 beats per minute, blood pressure normal or slightly hypertensive, and clear bilateral breath sounds. Electrolytes should be monitored closely during fluid resuscitation. Hyperkalemia can occur during the initial fluid shift when potassium leaks out of damaged cells into the vasculature. Correcting metabolic acidosis can temporarily resolve the hyperkalemia. Hyponatremia can occur in conjunction with hyper or hypokalemia. Fluid administration rates should be adjusted if fluid excess is present. A complication of excess fluid resuscitation is the accumulation of abdominal fluid resulting in a high intra-abdominal pressure, which puts the patient at risk for developing abdominal compartment syndrome. The patient's bladder pressure should be measured via the patient's urinary catheter. Intra-abdominal hypertension occurs when bladder pressure exceeds 30 millimeters of mercury. This is a slide showing a patient before and after the fluid resuscitation. The acute phase of a burn injury begins when the patient can maintain adequate urine output while receiving maintenance rates of IV fluids. This usually occurs within 48 hours after the burn injury. Nursing care during the acute stage is going to focus on wound management, pain management, prevention of infection, nutritional support, involvement in physical therapy, as well as psychosocial support. Patients with major burns are going to be in a hypermetabolic or catabolic state. Early implementation of enteral feeding improves outcomes in the burned patient by mitigating the degree and the extent of catabolism. Early enteral feeding preserves gut mucosal integrity, motility, and intestinal blood flow. Nutrition should be tailored to promote wound healing, to increase resistance to infection, and to prevent persistent loss of muscle protein. Patients with burns are going to require a minimum of 1.5 to 2 grams per kilogram of body weight per day of protein intake. Carbohydrates are the favored energy source for burn patients, as high carbohydrate diets promote wound healing and impart a protein-sparing effect. This makes carbohydrates an extremely important part of the burn patient's diet. However, there is a maximum rate at which glucose can be oxidized and used in severely burned patients, 7 grams per kilogram per day. Severely burned patients may have greater glucose needs that can be safely given. If glucose is given in excess of what can be utilized, it's going to lead to hyperglycemia, the conversion of glucose to fat, glycosuria, dehydration, and respiratory problems. The hormonal environment of stress and acute injury causes some level of insulin resistance, and many patients benefit from supplemental insulin to maintain satisfactory blood sugar ranges in between 80 to 110 milligrams per deciliter. Many authorities recommend a low-fat diet, less than 15% of total calories in burn patients, where no more than 15% of total calories come from lipids. Lipids that contain a high percentage of omega-3 fatty acids are metabolized without promoting pro-inflammatory molecules and have been linked to enhanced immune response, reduced hyperglycemia, and improved outcomes. Vitamins A, C, and D, iron, zinc, and selenium are important to promote wound healing. Patients with azotemia, which does not respond to hydration, may need a reduced amount of protein in their nutrition and need to be closely monitored for signs of renal failure. The rehabilitative stage begins when the wounds are closed and ends when the patient is at their highest level of function. The rehabilitative stage begins in the hospital when the patient is no longer acutely ill. The goal for a patient with a burn is to regain function and recover emotionally. Large burns are going to require pressure garments, continued physical and occupational therapy, as well as possibly reconstructive surgery. During the rehabilitative phase, the patient with a burn becomes aware of the extent of the burn injury and the effect on their appearance, as well as the effect on their function and activities of daily living. They may feel grief and loss, as well as hopelessness and loss of autonomy. Patients may become angry at both the burn team and the family. The burn team should work with the patient and the family. They need to help them to combat the feelings and also set limits, define achievable goals, and provide as much autonomy as possible. Post-traumatic stress disorder can occur, especially after discharge to home. The patient and the family must be taught about the signs of PTSD and instructed to seek help. The patient and family should be encouraged to become involved in a burn support group and meet other burn survivors who can validate their own experiences and instill hope for the future. The references you should use for this topic are Chapter 17 of the Critical Care book. We are going to be doing a series of case studies during class that will allow you to apply the information presented in this video as well as in your readings. Please bring the notes you take from this video as well as the Critical Care book to class, as there will be no actual lecture. Thank you very much for listening to this recording, and you have a great day.